All right. Good morning, everyone. I'm Robin Shapiro, the chair of HealthAdvocateX, and we're here for another community conversations. This is November 14th of 2022. And although it might feel like Groundhog Day, but we have a really exciting program ahead of us. But before we begin, I would just like to establish this meeting as a safe space. That means that every voice will be heard and respected, and we enter the space with different lived experiences. And as such, we recognize the potential for unintentional harm, and we're committed to healing should harm occur. I'd also like to say that I'm speaking today from Seattle, Washington, which is the unceded land of the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people. And I would like to acknowledge the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people and community and pay my respects to their past, present, and future elders. In addition to the fabulous Dale Reisner, who has since retired from Swedish as medical director of OBGYN quality and safety, we have two special guests today, Elise Goldstein, who is director of patient advocacy and community outreach for $4, and Scott Spivey-Provencio, who is the community organizer for that organization. We're going to be hearing about that organization and what they do to help support consumers in crushing their medical bills, which is something that we can all learn more from. But first, we're going to have an update from Dale on COVID-19 and some of the topical areas as we head into the holiday season. Dale?
Yeah, so I'm going to start with the usual data. Globally, we have over 635 million cases and over 6.6 million deaths. The USA is 97 million plus cases and over 1 million deaths. So 1/6 of the global deaths occurred in the US. A pretty poignant piece of data, I would say. The cases are falling, as you probably are aware. It's still about 288,000 cases per week in the US, and still a lot of deaths. So more than 2,300 deaths a week in the US.
Wait, can you say that? Can you say that again?
Yes, new cases across the country per week in the US, more than 288,000, wow, and more than 2,300 deaths per week. So people are still dying from COVID, and it will, I emphasize that a little bit because we're really highly vaccinated, and I'll tell you what those numbers look like. But it does speak to the fact that vaccinations are not 100%, no matter how good they are, and that we still need to be thinking about our ways of protecting ourselves and protecting our family members or our clients who are high risk. And most of the people that are dying are high risk, and with other comorbidities. So it is super important to just have a refresh that it's not gone. It's probably never going to be gone. Ideally, it will affect fewer people. I mean, the flu still kills people every year as well. It's part of our reality. But we are also seeing surges of flu for those who aren't getting flu vaccines, and RSV, which is respiratory syncytial virus, that previously was really hitting young children and older adults more severely, is causing some havoc with protracted illness that looks and sounds like COVID in terms of the amount of respiratory distress.
Is RSV like the flu in that it changes every year? Because I thought it was always the same, and pretty shocking that it's not affecting everyone.
Yeah,
So
no, it's around.
I'm a respiratory therapist. I'm
Chris,
so sorry.
Chris, mute, please.
Yeah, sorry.
Yeah, we're happy to get comments on all of this stuff as we come into the Q&A towards the end. But yeah, RSV is always around, and really our most delicate population that we look to are premature infants and children in the first year of life. It's just more evident in adults now because it hasn't been around for a while. And people are wanting to not wear masks and not stay away from large crowds. And you can see that when you go into any store. And so that is probably why we're seeing the middle adult age people. Often somebody with underlying asthma or some other respiratory issue that could make their susceptibility greater. So for COVID vaccinations, we have in the US, a total number of fully vaccinated people is over 80%, so that's great. The over 65 population is 95%, so they're the most vulnerable, and so that's good. But it's even in 5 years old and greater as high as 85%, and then it increases based on year of inclusion, 12 or 18. Obviously, the younger kids have vaccine availability a little bit later in time. So the vaccination piece is good. The boosters are the highest rate of boosters anywhere, and this is not common, is 25%. So average boosting is about 16%. So people are getting their 2 vaccinations, and maybe we'll see boosters higher now that it's fall, and some people are getting combination flu and COVID boosters. And just a comment about the current booster that's out is the bivalent. I would ask if you're getting a booster just to be sure, but all ages now are approved over 5 for the bivalent. And that is definitely going to give better protection to Omicron, as well as it still includes the original variants of COVID, which is why it's bivalent. It's both types. Both.
What do you mean? It's both types? Can you explain that?
It covers the viral components from the original virus, including Delta, and the Omicron changes for A and B. Gotcha. And so we'll give better protection than a recent booster that was monovalent, that just was the original variants. There's 2 companies that make the bivalent, and that is the 2 that started out. So both Pfizer and Moderna, either one should be effective. And if you had a prior monovalent booster, the one that's been available till summertime, you should, and you want to get the bivalent, it just CDC is recommending 60 days, maybe no more than 90 days waiting from that prior booster to get you better coverage. And that's a personal decision if you want to do that. If you're very susceptible, either severely immunosuppressed or elderly, then there's encouragement for getting the bivalent to have that better coverage. So that's where we're at with the vaccination stuff. I had some stuff about Paxlovid and a newer medication that can be utilized for people who either can't get vaccinated or are severely immunocompromised. I thought I would leave that for the end if we have time, so that we can hear from our guest speakers and also have time for Q&A.
That sounds great. And I do want to mention that Scott has to leave about 10 minutes early. So if you see him drop off, that's why. So let's get to it with Elise and Scott.
Yeah.
Thank you, Dale. And we'll come back around. I'm sure I have a million questions myself. So thank you for that strong introduction. So Elise, I'm going to turn it over to you.
Great. Thanks for having me. I'm going to pre-apologize. Apparently, my solar panels are getting installed above my head right now. So it's a little noisy in my house, but I'll do my best with it. So thank you for having me. I'm Elise Goldstein. I am the Director of Patient Advocacy and Community Outreach for $4. For some background, we're a national organization that was originally founded in Portland, Oregon in 2015 as a small dollar fundraising group trying to pay off people's medical debt. So our founder, Jared Walker, experienced a medical crisis in his family, realized how much a medical crisis could become a financial crisis, and started kind of fundraising to once a month pay off somebody's medical bills. In 2019, he became more aware of charity care, which I'll speak about in a moment, and $4 began to evolve. So what is, well, and then I'll say from there, started talking about charity care more, helping people in 2019. In 2021, Jared made a TikTok video talking about charity care and how people could get access. It was seen by 34 million people, and $4 had to become a very different sort of organization. So in the time since that video, we've evolved to a fully staffed organization. We're a team. Our number's a little fluid because there's lots of part-time people and consultants, but around 8 people. To date, we've crushed $20 million in medical debt, and we have some big goals for the future. So let me tell you about charity care. Charity care was written into the 2010 Affordable Care Act, and it said that nonprofit hospitals, in order to maintain their nonprofit status, have to offer a community benefit. And that community benefit is forgiving or reducing medical bills for lower and middle income patients. Now, this is regulated by the IRS in code 501R, and it is vaguely worded and not enforced. That leaves a lot of space for hospitals to manage the way that they run the policy. Every hospital must have a financial assistance policy. They must make patients aware of it by putting information on the bill and a sign in the emergency room. They must have the application and the policy posted on their website. However, beyond that, the work that they do to make patients aware is often very limited. In order to allow patients to apply, the hospital must have the application posted on the web. They must receive applications for 240 days from the date of the bill and consider that application for those 240 days. However, how that patient applies and what loops they jump through vary from hospital to hospital. That means that many patients are required to submit a fax application, including all of their proof of income, tax returns, or to mail it in, which for lower income patients often presents equally as big a challenge, because that means they have to have access to a printer to print all of their financial documentation. And then there's also a lot of hospitals can make this quite difficult through a series of loopholes. Each hospital gets to decide who qualifies in terms of the financial assistance level. So what their federal poverty level is that would let them qualify. And then they have and then they get to decide if there's any loopholes. So some hospitals will forgive debt for uninsured patients, where others will say, no, we own, or for insured patients, where others will say we only cover uninsured patients, or we cover uninsured patients and underinsured patients. And this is our specific formula for figuring out if somebody is uninsured. Hospitals can also create loopholes for residency, for citizenship status, for minimum bill. There's any number of ways that that hospitals kind of can make this harder.
Incredibly difficult, and who could possibly figure that out?
Yes, many of you might be doing it for patients occasionally on a one-on-one basis. So I'd like to introduce you to $4. $4, again, I said we're national. We're entirely funded by philanthropy, which means we are entirely free to every patient that we serve, and entirely free to the nonprofit organizations that we partner with to get out the word. We don't sell data. We have no back end that we're making money off of this. It's always worth clarifying that. So here's how we help. We make, yep. Seema, I will drop that in the chat, or Scott, if you don't mind dropping
I got
the
it.
URL in the chat. Awesome. So we say that we make charity care known, easy, and fair. Known is about conversations like this, right? It's getting the word out to patients that these programs exist, so that they then know, okay, I've got a hospital bill before I panic, before I throw it in the trash, before I pay a bill or put it on a credit card I can't afford. The first thing that patients should do is check to see if they're eligible for financial assistance. Now let's talk about easy. We have built internally a database of all 8,000 hospitals in this country and the financial assistance policies for each. And that database powers our eligibility screener. So any patient, anytime, can go to $4.org/help and fill out a 3-minute eligibility screener tool. They'll be told there, thank you, Scott. You can go to $4.org/help, or even better, you can go to the HealthAdvocateX URL that is in the channel, which will credit HealthAdvocateX as the referral partner for this. So the patient goes to this URL, fills out this 3-minute screener that tells us their name, what hospital they went to, their bill amount, their bill date, and how much money their family makes. And we're able to then calculate, are they likely to qualify for financial assistance based on that information and their hospital's policy, or are they unlikely? If they are likely to qualify, we are here to help. So we're going to do a couple of things. We're going to give them the option of self-advocacy and full service. If they choose self-advocacy, we're going to send them the link to their hospital's application, text, emails, reminders, step-by-step instructions along the way to help them apply and move through the process. If they choose full service, we're going to send them a longer form that we're going to ask them to fill out. It takes about 20 minutes. It's going to give us all the financial data that we need from them to then be able to complete the application on their behalf and submit it to the hospital, thereby saving them the fax situation, right? And then we're
amazing.
And then we're going to work with that patient to find a resolution. Like I said, to date, we've crushed $20 million in medical bills. Our goal for the next 3 years is to crush another 150 million. So we've got our work cut out for us. And the biggest challenge we have is for patients to even know that this service exists. We're real good at it. We know that patients don't know that these programs exist and that they might qualify for them, especially middle income patients who think, oh, this is only going to be for people at the real poverty level. Well, in this country, on average, hospitals forgive up to about 300% of the federal poverty level. That means that a family making $83,000 a year, a family of 4 making $83,000 a year, is likely to qualify. So most of this country qualifies, depending on their hospital and their particular financial situation. And then the last part I want to talk about is our Make It Fair work. So the way that we say we make it fair is that we are then looking at all the patients that we're helping, looking for trends. We're looking for where hospitals might be failing to live up to what's in their policy or failing to live up to the law, and then holding them accountable to that. We try and do that in a very hospital-friendly way. We're working first with the hospital before we're going out and blasting them. But I'll give you a recent anecdote. This always makes everyone's head shake. We identified a hospital who was forgiving patients financial assistance for maternity care because they were saying that maternity care was not deemed a medically necessary expense. We disagreed. We thought the law was on our side. We went back to them and we pushed, got their lawyers involved, got their board involved, and that hospital did then retrain their staff because their policy was accurate. It was their practices that were problematic. And so they retrained their staff, and we're working with them now to kind of go back through patients who were previously denied and hopefully get some of those patients that care. And moving forward, hopefully we will not be seeing patients denied for maternity care. I will pause there. And
I have a real quick question, Elise. Of that 20 million, how many patients? Is there some ratio
just crossed 1,000 patients. So
Oh, wow.
we hit $20 million and about 1,000 patients within a couple weeks of each other.
Wow, that's
So
great.
that's the ratio.
Yeah. Okay, thank you.
Sure.
Okay.
Should I turn it over to Scott?
Yeah, let's do it.
Awesome. Thank you, Elise. So Elise gave an awesome overview of what we do as Dollar4. I'm going to give kind of a few like more nuanced examples or local on the ground focus. So as I was introduced, I got hired on as a community organizer. I'll talk a little bit more about what that is, but I'm also actually a third-year medical student at the University of Texas at Austin, Dell Medical School. So I'm using a lot of my access and vantage points in the medical system and kind of leveraging that and using and doing community organizing, local on the ground work. So like Elise mentioned, most of Dollar4's outreach has been on the national level and through social media, where we really kind of went viral. No pun intended with the COVID talk right there, but now we're trying to kind of pilot what we're calling more local on the ground programs to try to reach people that are really in need of financial assistance. So I'm based in Austin, Texas. We also have a community organizer in Louisville, Kentucky. And basically what that looks like is partnering with local community organizations and trying to raise awareness about charity care and Dollar4 services so that they can point their clients in that direction. So here in Austin, for example, I've been partnering with groups that do tax prep, community colleges, local clinics, which I'll talk about a little bit more, and training their community health workers, their financial counselors, case managers. We have a specific training that you can sign up for on charity care and Dollar4 services. And this way, when they come across clients who might have medical bills, specifically bills from nonprofit hospitals, like Elise mentioned, we're able to kind of plug them into the eligibility screener, which I put in the chat. There's a specific HealthAdvocateX one now, and people can find out if they qualify for medical debt relief. Right now, kind of to tie this back into the general topics that were discussed, hospitals are crazy. So last week, 2 weeks ago, I was working in the children's ER at Dell Children's in Austin, Texas. And as you guys have probably heard in the news, as you can imagine, the waiting rooms are about 100 people long. I think the average wait time right now for an ER, especially at a children's hospital, is about 7 to 10 hours. And most of these parents are actually waiting that entire time. There's a really good academic article that just came out for those who are interested in a little bit more of the intricacies of the viruses, like Dr. Reisner was talking about. It came out 3 days ago in the Journal of the Academic Medical Association, JAMA, which is a really highly renowned article in the medical field, specifically about what physicians need to know on RSV, or respiratory syncytial virus, which is specifically a virus that typically affects children more, specifically infants. But we're also seeing with some patients with comorbidities and the elderly. The article is called "This Is Our COVID," about the pediatric RSV surge. So what's kind of really interesting about I know some people were asking the specifics about RSV this season, is that it came a little earlier. Typically RSV peaks in December and January, and we're seeing peaks in late October and so far the beginning of November. And part of this is because of coming out of the pandemic, right? Now a lot of people are starting to unmask more. We're seeing a lot more social events, large gatherings, and there's been what's called an immunity gap, where during the pandemic, a lot of people were staying home or masking more. And now specifically kids are a little bit more susceptible to a lot of these viruses. So most children, the vast majority of children will have had RSV by the age of 2, but because of the pandemic, we're now seeing 4-year-olds and 5-year-olds also developing really serious cases of RSV. And there's been some kind of concern, with the levels of capacity in the hospital and the long wait time. I just kind of want to give a quick little anecdote about how Dollar4 can help and how we're trying to empower patients. So like Elise mentioned, we help get financial assistance for hospital bills, and that tends to be typically retrospectively. We have to wait till you receive the hospital bill in order to apply for the financial assistance. But there's nothing preventing you from asking about charity care when you go to the hospital. So like Elise mentioned, it's not well known. I think there was a comment in the chat that many people do not know about charity care. But if we can get the word out about asking your hospital when you're there, seeing the doctor, waiting for the registration or whatever it may be called there, ask about charity care. Ask what financial assistance is available to me, because I'm afraid I might not be able to afford this bill.
And does it matter, Scott, if it's a nonprofit hospital or a for-profit hospital?
So the vast majority of charity care, like Elise said, is at nonprofit hospitals. Those are the ones that are federally mandated. Yet a lot of for-profit hospitals may have some sort of financial assistance program. It may be different. It may not be charity care, and the criteria may be different. But it's always worth asking upfront what financial assistance is available, or can I try to access. So when I was in the children's ER, I started talking to families about $4 and saying, hey, do you have any hospital bills? Are you expecting any hospital bills? I work for this nonprofit that helps provide access or help facilitate the process by which people can get charity care. One mother whose baby was actually there with RSV, she said, well, my kid is actually on Medicaid and CHIP, so he'll most likely be covered, but my mom just got a really big bill in the hospital and we're drowning with that bill. And she started crying there in the moment, just because she was like, wow, I've never even heard of something like this. So kind of also shows you that in families, especially, we were talking about this earlier today, in families that have maybe mixed immigration statuses or kind of different benefits, children can be covered by Medicaid and CHIP if they're low income. That doesn't mean that their other family members are not receiving medical bills, right? There was also another lady in the hospital who she was there also with her infant, who was about 2 or 3 months old. And I told her about $4, and she said, yeah, well, we're uninsured. We don't know how we're going to pay this bill. And when she was actually 32 weeks pregnant, she had a heart attack at 32 weeks pregnant, and she's expecting that bill. She has not received it yet because it's only been a few months, but she is expecting that big bill. And this is kind of part of the reason why we really want to raise awareness about $4 and charity care. So just to kind of speak briefly about what we're doing on the local level, here in Austin, we're trying to kind of pilot this outreach strategy, partnering with local organizations, and creating also what we're calling referral partnerships. So if you hear, for example, the people listening to this call, or you are familiar with any local clinics, one thing that we've been doing in Austin is getting plugged into their workflow. So for example, every clinic has typically a way that they refer patients to social services or social benefits programs. WIC, for example, Women and Children, that's kind of an example of some of these social benefits programs, but we're trying to get plugged into these clinics and let them know about $4. I've trained several community health workers and financial counselors at different local community clinics. And now we're receiving, this month alone, I think already 3 or 4 intakes of patients that got a big bill from the hospital, but they didn't know that when they were in the hospital, right? They don't know that they have the bill until later on. And then they go see their doctor as a follow-up from the hospital discharge. And they're like, well, now I have a huge bill that I didn't ask about in the hospital, right? So also trying to kind of catch people on the other side of the hospital visit once they're seeing their doctor or trying to follow up with organizations. And just kind of talking about how we're trying to scale this and work nationally. So we do have about, correct me if I'm wrong, Elise, I think we have about 200 plus volunteers all around the nation. We really rely heavily on our volunteers, and they're really helping us make it known. So by signing up to be a volunteer at $4, you're basically, we consider you kind of almost an ambassador, someone who's going to speak out about $4 in your community, either connect with organizations in your city, wear the $4 t-shirt, maybe even table at a health fair or a charity race or at a place of worship. Maybe even speaking for a minute at your place of worship next time you can get on the podium, and just talking about $4. We have a great community, online community on a platform called Slack, where we talk with all our volunteers, we share ideas. We also have monthly town halls, kind of similar to this, a community conversation where we talk about what's going on in our communities, give tips, and try to see how we can better get the word out, how to better make it known about $4 and charity care. So just an example, I'm going to put or Elise, if you want to put the volunteer link in the chat, if this is something you're interested in or know people who are interested in, we're always accepting volunteers. And then another thing I'm only going to mention briefly is we also have a partner page. And basically, if you have a community or if you have an organization, it doesn't have to be a community organization. It could be local or national. If you have an organization that wants to partner with $4, have access to some of our resources, and also even maybe get a custom URL, kind of like HealthAdvocateX did, we're able to do that and help streamline your impact and try to help you get the word out to your clients about how to access medical debt relief.
So do you have like a basic downloadable FAQ that we can promote or share? Because that would be helpful as
Yeah,
well.
that would be great.
Yeah, we have some FAQs and some, we call them like partner pages or information that we can definitely distribute.
Great.
And Scott, in prep the other day, didn't you mention that clinics that are not standalone clinics that are not affiliated with a hospital do not will not utilize $4, or I just want to get that word out because
Thanks for bringing that up. So a point of clarification. So unfortunately, doctors' offices or standalone clinics do not have charity care programs because that's specific to nonprofit hospitals. So if someone has any debt or medical bills that they cannot pay from a specific doctor's office, they will not qualify for charity care. Sometimes, and this is not a guarantee, so we tend not to kind of promote this from the get-go, but sometimes doctors are covered under certain charity care policies, but that's very specific to the hospital network that you're applying for charity care from. Every hospital network, like Elise said, can set their own criteria, sets their own rules about who qualifies for charity care and which doctors are covered under charity care. So it's always important to ask, well, first off, just ask kind of what are your financial assistance policies, either at a hospital or doctor's office, and see what kind of support that they offer. But we can always try to help you with a medical bill from a nonprofit hospital and then see if a doctor's office will honor that, for example. But these are just some specific examples.
Yeah, Scott, would you also include the doc in the box or the urgent care centers with that same guidance?
So yeah, that's a really interesting question, Elise. I might need some help here. So there's a lot of freestanding urgent cares, and I know that's also a big thing that's being hit hard right now. Wait times are about 3 hours at the urgent cares for those who are not trying to go to the hospitals. However, a lot of these are for profit. A lot of these urgent cares or freestanding ERs are typically for profit and may not have a charity care option. Elise, do you want to add more to that?
Yeah, it really depends. Is like almost everything in charity care, the answer is it depends. So there are often independent clinics that are affiliated with nonprofit hospitals in communities. The law is specifically covering nonprofit hospitals with trauma centers or emergency rooms. So that means that the hospital can, by way of the law, say that this freestanding clinic doesn't necessarily qualify for financial assistance. Now, some systems are better and just cover them, and some do not. And there's not a lot of regulation to strengthen that. An anecdote I shared last week, we had a patient, looping back to the COVID situation, where she went to one of these freestanding clinics associated with a large hospital system. Her family got 2 COVID tests and was billed $1,800. There were any number of reasons that this bill was problematic, up to and including it was during the time when bills were supposed to when they were supposed to be free. We fought the system quite hard, saying, hey, everything should qualify this patient for financial assistance according to your policy. And they were pretty firm on, but we're denying her because it was this freestanding clinic and therefore was not covered. Now, ultimately, that patient's bill was resolved when a journalist for a large national paper was looking for a story, and we referred her to them, and she called up the hospital and the bill just magically went away. But obviously that is not a mechanism we can use for everybody. So it is something to know, and it's an interesting and tricky nuance to live in for these low-income patients, right? Because like we know hospitals are overloaded. We know that hospitals don't have a ton of capacity to get right to care for everybody. But for a patient who is low income and uninsured, they may be better off at the hospital location than at the local clinic. $4 will always say that our role in the process begins when the bill exists. We don't advise patients on where to get care because there's so much nuance to it. Should they be insured? Should they be uninsured? Where should they go? There's a million loopholes. We don't want anybody to walk into a hospital counting on charity care and not get it because their hospital has decided to enforce some ridiculous reason why they're not going to. But it is a space where patients can educate themselves and kind of try and do a little analysis to help alleviate some concerns and support some concerns.
Elise, Beth Burnett wanted to know if you are going to get your organization listed on Charity Navigator.
Yes, absolutely. So like I said, in 2021, in January, we were a one-person organization. So we actually, 2022, this coming year is the first year we are going to actually need to file a full 990, which is what qualifies us to be on Charity Navigator. So the reason we're not there now is that we weren't big enough. That is changed in the past year, and so you'll see us on there soon. There was another question related. Lisa asked who funds $4 and who funds the hospital's charity fund, so I'll answer those now too. Who funds $4? The answer is independent philanthropy and major donors. Because we are such a small team, we have significant technology that supports our ability to do this work, which means that the tech bro community has been very kind to us. So we have a lot of support, and tech bro is an unkind word. I'll take that back. But we have a lot of support from a lot of people in the technology space, but a lot of also foundations is where we're getting our funding. And in terms of who funds the hospital's charity fund, it doesn't really work that way. They don't have a pot of money from which they're pulling. The best kind of analysis that we can do, the Loan Institute has done some analysis on this. So basically the hospitals have to write off the bill if it qualifies for financial assistance. The Loan Institute has done this study and basically looked at how much hospitals are not paying in taxes because they're a nonprofit, and comparing that to how much they are giving in charity care. And they're calling it the fair share deficit. And it's a deficit because of almost every hospital in the country. They are getting more of a tax benefit than they are giving in charity care. The other thing to note on this is that almost always these patients are patients who would not pay their bill because they cannot pay their bill. They simply cannot afford these bills. And so this is not a case where hospitals, if they didn't give the charity care, would all of a sudden have more income. They would instead be spending a lot more money sending debt collectors after people who aren't going to pay. Right. So for the hospital, most of the hospitals that we've talked to basically say this is a win-win for us, right? They we're not chasing people who can't pay. We're saving money in debt collections, and we're reporting it to the IRS as our community benefit.
So I have a couple questions for you, Elise. What if a patient has a very old bill or a bill that's already gone to collections? Can you guys still help?
Yeah, it depends. So the law says that hospitals have to consider applications for up to 240 days from the original bill amount. Now, the law also says that the hospital can send the patient to collections at 120 days. That means that oftentimes bills are going to collections that are still legally able to be forgiven for financial assistance. If the hospital or if the patient applies to the hospital after it's been sent to the collections, the hospital still has to pull it out of collections and forgive it. So we always encourage patients not to consider collections game over. We definitely know that patients get that collections bill and they think, well, there's nothing I can do. What do I do now? Right. That said, the 3-year-old hospital bill very hard to get
Mhm.
overturned. 240 days, some hospitals will give up to a year. Some don't have a date in their policy, at which point we will try anytime. But it can be a hard sell past the 240 days.
Mhm. Mhm. And are you seeing a lot more action because of COVID? Do you think that that's one of the reasons why your organization has been growing?
Not necessarily. We definitely have, I wrote down the number. So we've seen about $2 million in intakes from COVID. Since we started tracking the reasons for intakes. It's an optional question that patients can share with us what their hospitalization reason is. So we don't have it for everybody, and we only have it from about February. But in that time, we've seen about 2 million. We've also seen about 100 million in intakes during that time. So it's by no means the largest factor. But the average bill for a COVID patient in our system is $23,000. So these are big bills.
Wow. Yeah.
People are getting hit.
I'm surprised it's not bigger than that.
Yeah.
Yeah.
Because usually when you need to be admitted, you're pretty sick. So that will have changed, because if the majority of people are vaccinated, even if they require hospitalization, ICU admissions will be lower and so on. So that part's good. I suspect, and you can tell me if I'm wrong, that you're going to see more from the states that didn't do Medicaid expansion.
Yeah.
And so you're good. Yeah. And that's,
Absolutely.
and so, for instance, the state of Washington, so many people are covered compared to, say, the state of Texas. And I noticed that, I think it was Arkansas in this last midterm election that there was a plan to go ahead with Medicaid expansion. So hopefully the states will get the clue that if federal dollars are available, you should be taking them, because it's hurting the patients, their families, and it doesn't help the state either.
Yeah, for sure. We've done it. So we say that our target populations, when we're looking at with an equity lens at who we want to be serving most, we're looking at Black and Brown communities, immigrant communities, disability patients, and then Southern states and non-Medicaid expansion states. So those are kind of the list of where we see medical bills generally being higher in those particular communities. And so when we're thinking about where and who to target resources to, that's the analysis that we're doing. But yeah, we have state overlay maps of intakes, and like Texas is bright orange, and Florida as well, and Georgia. There are certain states where we just see a lot.
And I just wanted to make a quick plug there that Elise hit the nail on the head. So like COVID, medical debt disproportionately impacts these communities.
Yes.
These low income communities of color, uninsured, which is just kind of farther exacerbating all these effects. But $4 is committed to trying to make an equitable outreach. Trying to reach these communities. Hence, a lot of the local community efforts. We did go bilingual as of a month ago. So now all our services, all our tools online are in English and Spanish, which I know is a huge need for a lot of organizations. So just kind of making that aware as well.
So can you, Scott, I know you have to jump off in a few minutes. So before you go, can you just, again, let us know if an advocate wants to get trained in this area? What are the virtual trainings that you offer? Like, how long is it? When are they held? What would people hope to learn and take away for their clients?
Yeah. So, and then Elise, correct me if I'm wrong, but right now, I think we might have discontinued the in-person, or not in-person, I guess, the live trainings, but we do have a recording now. So if anybody signs up to be an individual volunteer on the volunteer page, or if an organization signs up to be a partner on our partner page, they will have access to these online trainings. It's only about a 20-minute video, but it covers all you need to know about charity care and how $4 works and how to kind of get started with us. That being said, once you partner, quote unquote, with us, kind of between Elise and myself, we're happy to do a live training for your organization. So let's say you have, 30 advocates or you work with a specific population, we're happy to kind of do a more targeted training there.
Fantastic. That's great. Is there anything else before you have to hop off that you would like to share with our audience?
I don't think so. Elise, anything on your mind that you might be thinking of?
Thank you, Scott.
Thanks for your work, Scott.
Yeah, we really
It's
appreciate it.
amazing work, you guys. It's
Yeah.
so impressive, and the growth that you've had over the last year, it just it's heartwarming, and definitely needs to be advertised and shared across different communities and different parts of the country. I see. It's sad to me that that's what needs to happen in order to get it right for the patient
Yeah.
and their family. But it's just amazing work. So
Yeah.
thank you guys.
Very, very nice tool for advocates and family members.
And Scott, I wanted to just respond to you. I asked about international. I did some helping with vaccines in Wyoming. And there's a huge immigrant community there, and they go back and forth. And sometimes they have bills there and sometimes here, and depending on whether or not they're legal. I'm curious if you guys can do work with illegal immigrants.
Yes.
Okay.
So our stance, we just had a meeting on this. Our stance has been and will always be, we don't ask about immigration status and we don't communicate that information to the hospital. There are some hospitals who have a residency or citizenship status as part of their loopholes. So but they're not super common. But in rare cases, a patient will just get flatly denied because the hospital will ask for some proof of that and the patient won't be able to provide it. The more complicated and more common situation that we're still learning to navigate is the patient who is a non-resident of the US and therefore doesn't have documentation to prove income. So how does a patient show that they are low income if they have no tax returns, no pay stubs? We have kind of like the things we've tried, some of which work and some of which haven't, things like, okay, is somebody in your family supporting you? Can you write a letter of support showing bank statements, international bank statements? We've had patients from Venezuela where they submit their bank statements and then, we show them the currency conversion that this person obviously cannot pay the bill in the United States. But we are actually kind of actively building our own expertise around this because we're not yet experts on it, and we want to make sure that we can answer patients' questions and serve them appropriately. That said, they shouldn't avoid coming to us yet. We will try.
Thank you.
Bye, Scott.
Bye, Scott.
Bye.
Thank you.
Thanks. Thank you. So great. Really appreciate it. And Dale, I want to jump back to some questions that I'm sure are on the minds of people who are listening to this broadcast. And we're heading into Thanksgiving. The last couple Thanksgivings have been, interrupted. So do you have any advice for people that are trying to figure out what to do? It feels like we're planning a huge Thanksgiving this year. And I'm just kind of wondering, because lurking in the back of my mind is holidays interrupted from last year and the year before.
Yeah. So, I think that, I'm going to sound like a broken record, but if you're boosted, especially if you've got a bivalent, now you're running out of time to get full protection if you want it by Thanksgiving. But if for the winter holiday season, if you can't make it by Thanksgiving, and you know you're going to be around a large family gathering, I would strongly encourage that bivalent booster. You're not going to be able to mask during a big family meal. You're going to get sick. Some people are going to get sick. So I think you just need to know if you're elderly, if you have other comorbidities, that you make a personal decision whether you go and do that or not. I personally had COVID, which I picked up at a large gathering in Hawaii at the end of the summer, and I did probably a little on the early side, just get the bivalent because I'm going to be around some extended family
After your COVID, you got the bivalent. Okay.
I did.
Mhm.
And you can. So the recommendation from the CDC is 60 days, although post-vaccination, any kind of booster or completing the series, the recommendation for the bivalent is 60 days. So I kind of went in between and just decided I would do that a little bit early. So you can, if you got boosted, in the summer, you certainly can go get the bivalent now. Almost everywhere has bivalent only for boosting now, not necessarily for the full series. I'm not sure what the status is for the full series. They may be giving it for that too. I don't know. And then if you haven't had flu, I would get flu vaccine as well.
Sure. And
you can do
we
them both together. And
yeah,
you shouldn't
and just to and just to we did have a question about this. Even if you've had the 2 boosters, people should be getting the bivalent.
Yeah.
Just make sure
That's
everybody's
right.
clear on that. Yeah.
So I think what we're going to be looking at is kind of like the flu vaccine, right? So that each year they do a new one, and we'll be wanting to get the winter, kind of the fall indoor gathering type of coverage every fall. And I'm thinking it's, unless we get some weird, really devastating variant that comes along, that will settle into that once a year, something that, covers whatever the modifications the virus did the year before. The other thing I wanted to mention is there is a new emergency utilization authorization medication available, and you may have either family members or clients that will qualify for this. I'm not sure exactly how available it is. It's called Evusheld. I keep thinking it's Evusheld, which I sort of think that would be a better name, but Evusheld.
How do you spell that?
Evusheld. And it is a combination of 2 antivirals that I can't pronounce very well, so I'm not even going to tell you what they are. And they are specifically for pre-exposure. So if you were around somebody and you've been exposed, or if you've got COVID symptoms yourself, that is not a drug for you. It's particularly pertinent for somebody who is severely immunocompromised. And we know that some of the immunocompromised people are not getting the same protection from the vaccinations. And we also know that there's a small subset of people that can't have full vaccination status because of a severe allergic reaction to the vaccination in the first place. That's a really small, many of the people that say they're allergic are not. It's a small population that really cannot have the full set. And so this particular combination of antiviral medications that are for pre-exposure. So if you know you're going to be around a gathering, if you know you're going to be out in public, if you're going to travel, those kinds of things. I think looking at the immunosuppressed population, the people that are on chronic immunosuppressive medications, cancer therapy, you name it, worth talking to the provider to say, do you have access to this? Is it helpful for me or my client? I just wanted you guys to all know this is something I was not aware of until recently. And it's promising for people that are not able to have the same level of coverage as those of us who aren't immunocompromised in a big way.
And we did have an advocate online, Melina Aline, who also just wanted clarification that if you get EvuShield, you're not going to be getting the bivalent booster.
Correct.
Yeah.
Correct.
Okay. Just so people understand that. So
yeah, it's really meant for people that really either can't, or I think it's new enough that we don't know if you could use it in combination with the bivalent or not. But it's really meant for people that have either vaccine inability or known minimal, minimal response to vaccinations. And so there may be a role for the bivalent and EvuShield in the future. It's not clear.
Yeah.
The one other thing I did want to mention is Paxlovid. So if you are exposed, this is not necessarily recommended, but if you have an early COVID infection, if you're over 65 or you're at risk for severe illness due to other comorbidities, cardiac, diabetes, significant obesity, et cetera, within 5 days of symptoms or a positive test, Paxlovid is available to you through your healthcare provider. You need a prescription for it. It is 3 pills a day for 5 days. There is a lot of talk about rebound. So I just wanted to just briefly mention, I've re-looked at rebound, and what was available to us with the original data was that the rebound from Paxlovid was very similar to those who were on the placebo, who got the native virus COVID, right? So that was about 3.5%. Over time, it appears actually that has held. And actually the COVID infection rebound rate is thought to be around 5%.
Okay. Well, that's a lot different than what I think has been portrayed out there. Yeah.
Right. And so there's been some guesstimates because the data is not full. There's not a great reporting system for rebound. So the guesstimates are that maybe the rate from Paxlovid for rebound is closer to 10%. So somewhere between 3 and 10%.
Interesting.
I think we will watch that and see, but I think everybody really needs to understand that COVID itself gives you a somewhat of a risk for rebound. And when we first started hearing about COVID, we saw this, right? We saw people, they were saying, is it a new infection? What is it? And so it comes along. If you are really at risk, I would recommend talking to your provider about Paxlovid. And there are some medications it doesn't go well with, some of the cardiac meds. So you need to be careful of that. And in the chat, Paxlovid is associated with a lower risk of long COVID. So if you're afraid of that, it may be worth looking into as well if you fit the criteria.
Yeah, thanks, Seema, for putting that in the chat.
Yeah.
And one of the things, maybe real quickly before we have 2 minutes left, is in thinking about what our hospitals face, both from RSV, flu, and COVID. What are you seeing? What should we be telling our family, friends, patients, clients in terms of what we're facing and what to do?
Well, across the country, we do not have enough healthcare workers. Our emergency rooms are going to be crammed. The pediatric emergency rooms and hospital units are way overloaded. We will be needing to keep pediatric patients in emergency rooms for longer periods of time, even after they've been diagnosed, and we know that they need a bed because there won't be enough beds. Yeah. Our best bet is as much prevention and protection as possible that we can do within our own realm. And that might be avoiding a big Christmas or whatever, if you have a child who's at risk for severe illness, whether it be RSV or COVID. And there are environmental things that are happening. We have had huge problems with pediatric admissions because of the smoke in the West from forest fires. And that towards the end of the summer was tying up pediatric ICUs and all of that. So I think that the combination of looking at the cost of care, as much prevention as we can do, and if you do need to go to an emergency room, if your clients know where the not-for-profit, as Elise says, not-for-profit is not pain-free. And our hospital system just went through a huge issue that none of us as providers knew about with an outsourced billing service that was not doing a proper work with charity care that we thought we were, and we spend millions of dollars on charity care, and it was not being done properly. So organizations like Elise's with $4 are huge, but we do need to look at our own communities and help our clients, go places that will treat them as well as we can expect, and that at least there's some resource to fight back with.
Yes. And with that, I'd like to just say thank you so much to Dr. Dale Reisner, Elise Goldstein, and Scott. This was a really great community conversation, fantastic. And I just wanted to give a heads up to everybody who's listening. We will do a December 12 community conversation. We're going to be trying to get a speaker alongside of Dale Reisner, who will be talking about mental health, because that's something that everybody's kind of thinking about around the holidays. And we wish everybody a wonderful Thanksgiving. And in this time of Thanksgiving, we're just very grateful for this community, very grateful for this information. So thank you so much, and hope to see you December 12th. And if you're an advocate, we do have a networking event on December the 8th at 4 p.m. Pacific time. So hope you can make it then. Bye-bye.
Bye, guys. Thanks again, Elise.